At RSNA 2023, experience the future of medical imaging when the radiology community comes together as we help you discover how to lead through change. Immerse yourself in the latest technological developments, see imaging innovations in action, sharpen your skills with high-impact learning, and connect with radiology colleagues from around the world. Join us November 26th through the 30th for the biggest week in radiology, in person, virtually, or both. Register now for RSNA 2023 at rsna.org/register. Hi, my name is Matt Covington from the University of Utah and Huntsman Cancer Institute. Welcome to the RSNA Radiographics podcast. I will be talking about the article 18F-Fluoroestradiol, Current Applications and Future Directions by authors Sophia O'Brien, Christine Edmonds, Shannon Lanzo, Joanna Weeks, David Mankoff, and Austin Pantel. This is a fantastic article on fluoroestradiol PET imaging, which is commonly referred to as an FES PET scan. This article focuses on approved clinical uses of FES in the United States. The authors begin by providing some key information about breast cancer, which is the most diagnosed cancer in women worldwide, and in the United States, the second leading cause of cancer death in women following lung cancer, and the leading cause of cancer death in Black women. Upon diagnosis of primary or recurrent breast cancer, it is standard practice to test receptor status, which in current clinical practice is performed through immunohistochemistry on biopsy specimens for markers that include the estrogen receptor, simply referred to as ER, progesterone receptor, which I will refer to as PR, and ERB-B2 receptor, that is ERB-B2 receptor tyrosine kinase 2, which is formally and still commonly referred to as HER2, for human epidermal growth factor receptor 2. It is important that hormone receptor-positive cancers have improved treatment options, including ER-targeted therapies, known as endocrine therapy or hormone therapy. These include therapies such as aromatase inhibitors like anastrozole, selective ER modulators like tamoxifen, and selective ER downregulators like fulvestrant. There are limitations to assessing ER expression through tissue biopsy. For example, some sites of disease are poorly amenable to biopsy. Osseous metastases have a relatively high false negative rate for ER positivity on immunohistochemistry, and for more disseminated disease, it is not feasible to biopsy every tumor site, which limits our ability to detect heterogeneity in receptor status. For example, some sites of tumor may be ER positive, and others may be ER negative in the same person. If only a single site is biopsied, it would not be possible to know that heterogeneity in ER expression exists between these tumors. All this matters for FES PET imaging for several reasons. What exactly is FES? The authors state that FES is an 18-fluorine labeled estradiol analog that binds to estrogen receptors for use with PET imaging and anatomic correlation with CT or MRI, as in a PET-CT or PET-MRI study. FES PET is currently approved in the United States for patients with ER-positive, recurrent, or metastatic breast cancer as an adjunct to biopsy. Through PET imaging, FES can provide useful information regarding ER status and possible ER heterogeneity, presence of ER-positive breast cancers, identification of biopsy targets for confirmatory biopsy, and clarification of equivocal findings on other imaging studies to include an FDG PET scan. What is the normal biodistribution of FES? The authors describe key aspects of the normal distribution of FES to include the highly ER-expressing uterus, as well as the liver, which is the radiotracer's critical organ, and the gallbladder, bile ducts, small bowel, kidneys, ureter, and bladder, as these are all involved in the metabolism and excretion of FES. Additionally, retention of FES within the veins of the arm and the upper chest on the site of injection is typically seen. What are key aspects pertaining to patient preparation, radiotracer administration, and imaging protocols for FES? According to the authors, FES either needs to be performed prior to administration of ER-blocking drugs like tamoxifen and fulvestrant, or else imaging should not be performed until after a washout period of 8 weeks for tamoxifen and 28 weeks for fulvestrant to negate the potential of a false negative FES scan for ER-positive disease. FES may be performed in patients currently taking aromatase inhibitors because these agents do not block the estrogen receptor. Physiologic estrogen levels also do not affect FES uptake, so FES can be performed before or following menopause. Patient preparation is otherwise simple in that a negative pregnancy status should be assured and adequate hydration and frequent voiding should be encouraged. No specific dietary restriction is necessary prior to FES imaging. Breastfeeding should be avoided for 4 hours following administration of FES. The recommended dose of FES is 6 millicuries, which is 222 megabecquerel, with an accepted range of 3 to 6 millicuries, or 111 to 222 megabecquerels. Imaging is optimally performed 60 to 80 minutes after FES injection and is typically performed in the supine position, often with the arms above the head. What are key pearls and pitfalls for FES imaging interpretation? The authors provide several key pearls and pitfalls that are useful for radiologists and nuclear medicine practitioners interpreting FES PET scans. First, FES uptake is specific for functional ER expression. Sites of FES uptake outside of the normal biodistribution that have uptake above same tissue background levels are considered FES positive. Unlike FDG, uptake of FES is not seen in inflammatory, degenerative, or other reactive processes. Therefore, FES uptake at sites like the bone marrow or lymph nodes that is above background levels should not be assumed to be reactive or inflammatory, but rather represent ER-positive disease. One notable exception is radiation pneumonitis, which can demonstrate increased FES uptake, as well as lung atelectasis. According to the authors, a maximum standardized uptake value, or SUV max, of greater than or equal to 1.5 is one of the currently accepted standards for identifying FES-positive disease. I would note, however, that several clinical trials have also used SUV max thresholds for positivity that slightly differ, though an SUV max value of 1.5 is likely the most common threshold that I and others have used in FES clinical trials. One key message of this article that anybody interpreting FES PET scans should pay attention to is that the average SUV of FES-positive disease is lower than that typically seen with other radiotracers. So, readers must remember to window images appropriately when interpreting FES PET images. In evaluation for sites of primary disease or metastasis, the SUV upper window should be set at between 2.5 to 5, and often toward the lower end of this range per the authors of this article. However, using such a narrow window will make certain organs such as the liver, bowel, and or bladder hyperintense. When evaluating such organs with high background uptake, it is also important to adjust the windowing to a higher upper SUV range, such as something like 20, to best ensure that intense physiologic uptake does not obscure nearby disease. Therefore, when interpreting an FES PET scan, the reader must use active windowing to evaluate for primary disease and also should adjust the windowing to better assess organs and adjacent tissues to organs with high background FES uptake. FES is particularly adept at identifying disease sites in lymph nodes, bones, and in the lungs, which are common sites of breast cancer metastases, as well as the brain. However, identifying disease in the liver is currently limited due to high physiologic background uptake in the liver. A key pitfall in FES imaging is the interpretation of FES negative lesions. An area of uptake potentially suspicious for a site of breast cancer on other imaging that does not show positive FES uptake may represent a benign lesion or an ER-negative breast cancer. If FES-negative disease can't be ruled out on the basis of imaging or clinical findings, biopsy should be performed whenever feasible for confirmation. What are current clinical indications for FES PET-CT in patients with breast cancer? FES is approved for use in the United States as an adjunct to biopsy in patients with ER-positive, recurrent, or metastatic breast cancer. Current specific clinical indications of FES include to select biopsy targets to stage disease, for in vivo assessment of ER-positive disease burden, including clarification of equivocal findings on other imaging studies, to determine spatial and/or temporal heterogeneity through confirmatory biopsy. This means that FES can potentially identify heterogeneous ER disease, meaning presence of both ER-positive and ER-negative breast cancer metastases at the same time point in the same patient, or development over time of what may be initially ER-positive disease in a patient that thereafter transitions to ER-negative disease. By providing large field of view imaging, FES PET-CT allows assessment of receptor status systemically in comparison to ER status by immunohistochemistry that is typically performed from biopsy of only one or a few sites of disease. In addition to this article, the Society of Nuclear Medicine has recently published appropriate use recommendations for FES PET imaging that provide further insight into current clinical indications for FES PET-CT, including use of FES PET-CT at time of progression on endocrine therapy to evaluate for potential use of second-line endocrine therapy. What are limitations of FES PET-CT imaging? As already mentioned, FES is limited to evaluate for disease in organs with high background uptake, such as the liver. False positive imaging findings for breast malignancy can include other ER-positive entities, such as a uterine fibroid or a meningioma. Radiation pneumonitis and lung atelectasis can also show some degree of FES uptake, as I previously mentioned. False negative results on FES PET can result from small lesions, lesions with low ER expression, and lesions within or adjacent to areas of high background uptake of FES, such as the liver, bowel, and the uterus. What are potential future uses of FES PET-CT imaging? According to the authors, potential future uses of FES include initial staging of invasive lobular carcinoma, which can be occult or understaged with conventional breast imaging. This is a potential use of FES which I am studying in clinical trials and of which I am enthusiastic about. FES may also be helpful for staging low-grade invasive ductal cancers and other low-grade ER-positive breast cancers pending results of future studies. Other potential future uses of FES include evaluating response to ER-targeted therapies, as well as to use FES to demonstrate presence of effective ER blockade with ER antagonist therapy, with FES potentially being useful for dose determination. In essence, one would perform a baseline FES PET scan to document uptake in lesions, dose a patient with an ER antagonist or ER blockading therapy, and thereafter image with FES to see if FES binding to the ERs has been partially or completely blocked or prevented. Therefore, an FES PET scan could potentially guide dosing of such ER-targeted therapies in a clinical trial environment or potentially in future clinical use. Finally, FES could be helpful for imaging evaluation of other ER-positive malignancies, such as things like endometrial cancer. In closing, I wish to congratulate the authors of this radiographics paper on providing such a useful and succinct guide to FES PET imaging. I urge listeners to also review this article in print for complete review, including to review many helpful figures which the authors have provided and annotated, which can aid the reader to improve FES imaging interpretation. I also want to inform the listener that an invited commentary on this radiographics article that was written by Dr. Amy Fowler, called "A Recently Approved PET Imaging Agent to Guide Breast Cancer Therapy," is also helpful and provides additional context to this article that I have discussed by Dr. O'Brien and team. Quoting Dr. Fowler in this article, she states, "The article by O'Brien et al. Is an excellent resource as clinical implementation of FES PET-CT expands. I couldn't agree more, and I would refer anybody who is starting to use FES PET in clinical or research use, or those who simply want to learn more about the use and interpretation of FES PET imaging, to read the article by Dr. O'Brien and consider additional insights that are provided in the associated commentary by Dr. Fowler. I also wish to thank the editors of Radiographics and of the Radiographics podcast for inviting me to present this review. To all listeners, remember to keep on learning.